Check two. Okay, there it is. Check two. Check two. Check two. Okay, so
Can I turn on the room audio and just see if it's working?
audio's not working. I need 10 minutes.
Hello, sir.
Testing, testing, testing. Testing, testing.
Check two, check two. Time is it? 5:32.
So the dean's about to start. So are you able to?
Are you already recording? Okay.
Okay.
Okay, now if I can get people to stop bumping this camera. Well, we are hearing this on our recording. See? There I am.
Okay.
Hello. I just don't know why it's not going
It's
up
just
there
that the
now.
room won't hear it. But the room can hear the lapel mic, so we can pass it.
Speaker, if I could bring that speaker back over here.
What speaker?
It's out there that they had me run for a projector that I can't even hook up now because it just showed up. And we already started.
Just get that.
I gotta do that.
New strain, that has not been previously identified in humans. To date, the novel coronavirus has infected more than 31,000 people. It has spread to 25 countries and led to more than 600 deaths. 12 cases have been reported in the United States, including 4 here in the Bay Area. So in a few minutes, we'll be hearing from our speakers who will discuss what we know and don't know about the novel coronavirus, why these outbreaks are so difficult to predict and prevent, how the media have been covering this issue, and how we in the public health community can best respond. So with that, I'd like to introduce our speakers. Art Reingold is the division. Professor Reingold has health issues of note at Daily California for home. Director at the has a special clinical diseases and underserved populations. She also consults for the City of Berkeley Public Health Division.
Conversation with Erin about a variety of things, but we're planning to leave a large amount of time for your questions and for questions. So don't get frustrated. That's a major part of what we'll be doing. And I also this is a very that everyone in the room has access to. So you can go online and look at the website or the WHO website or the New York Times or scientific papers which are published electronically. That's what I did, right? I haven't been to China, although I am supposed to go to Malaysia. The genetic sequence is about 80% similar to the SARS coronavirus, so fairly closely related to the SARS coronavirus. And it's 96% similar to a coronavirus found in this creature, the horseshoe bat. So I think all of the early reporting that could this have come from a fish, could this have come from a bird, I think those of us who know about this virus were quite convinced from the outset that this came from a mammal, an infected animal. And I can't explain any of that, so I'll ask Eva Harris to explain it if you have questions about it. Many of you know that before SARS, we knew about coronaviruses, and they were considered to be basically the cause of minor upper respiratory infections that were self-limited. And no one paid much attention to them because they didn't cause that much morbidity or any mortality. It wasn't until 2002 with the outbreak of SARS that began in South China and then went to Hong Kong and a variety of other countries that people got interested in these viruses, and then particularly when a coronavirus caused the Middle Eastern respiratory syndrome as well, that the interest picked up even further. So just to remind you what happened with SARS, I happened to be in Hong Kong during the SARS epidemic, so it's still fresh in my mind. But you can see that at least according to the WHO summary, the SARS epidemic produced 8,422 cases, many of them in healthcare workers who were exposed occupationally before isolation procedures were put in place to protect them. There were 916 deaths for a case fatality of 11%. Cases were detected in 32 countries, and we had 33 here in the United States. But as you know, that outbreak was basically brought to a conclusion. You can see within about 8 months. There have not been any further SARS cases in the world that I know of since that time. And so you could call this a public health success story in terms of bringing this particular outbreak to an end. So, of course, I made this slide this morning. It's already out of date, so that illustrates one of the issues, which is that these numbers are constantly updated. So the dean mentioned 31,000 cases, and by now it's probably 33,000 cases. So you can check, you can go on your cell phone and see what someone is saying now. But clearly, this is an enormous problem. You can see approximately 600 deaths so far. But I think everyone knows, if you read the newspapers, that we know that these are extraordinarily likely to be underestimates of the number of cases, even bigger underestimates of the number of people infected, and quite likely an underestimate of the number of people who have died. So really, we don't know a lot, but you can take these numbers for what they are. And of course, this map shows that the fact that the vast majority of the cases are in China, particularly in Wuhan, but there has been spread to other countries in the world. And so this was the map as of 9:30 p.m. Eastern Time on February 5th. Undoubtedly, the map is different now, but that was the map as of last night. And here you can see the distribution of cases, again, by country, and I'll get to the United States in a minute, but clearly we have had transmission basically by travelers either returning from China to these countries or traveling from China to these countries, and to a very limited extent, in a few instances, transmission within those countries to a close contact. Okay. So in the United States, at least as of last night, there were 12 confirmed cases in the United States, 6 here in California, 2 of them in Santa Clara County, 2 in San Benito County, 1 each in Los Angeles and Orange County, and then 2 cases in Illinois and 1 case each in Arizona, Massachusetts, Washington, and Wisconsin. Now, this does not include individuals who might currently be quarantined in Army or military bases in California and elsewhere, but as far as I know, there are no confirmed cases in any of those quarantined individuals as of this date. I just want to, this is a public service announcement. So this is from the newspaper about the response to the case in the state of Washington. And I just want to point out what it says here, that the emergency is global, but it's public health officials who isolate the sick, trace close contacts, and deliver thermometers. And it was a friend of mine, Jonathan Mann, who some of you may recognize his name from the AIDS epidemic. Well, before that, he was a state health officer in New Mexico. And he convinced my wife and me that if you really want to do public health, you should be at the local level, because it's local public health that really has to respond to problems like this. And I would just like to point out that it's schools of public health like ours that train the people who go out and do this work at the local level. So I take enormous pride in knowing that people who graduate our school and other schools are really at the front lines doing this work. So this is just to say that these are people under investigation. You can see, even though this was the same date, February 5th, it's actually, the CDC lists only 11 confirmed cases when it's 12, but you can see that a number of other people who were under investigation have been ruled out as SARS, and there's still a number of people being actively followed to see, the novel coronavirus, and there's still people under investigation by the CDC in a variety of locations around the world, around the country. My friend Nick Jewell has already pointed out to me some of the challenges with modeling. I already knew some of the challenges, I just didn't understand the mathematics underneath them. But there are a number of groups that are doing sophisticated modeling to try and make projections of how many cases there might really be in the world, how many infections there might be in the world, projecting things into the future, and those numbers are pretty grim. Frankly. So this estimate was about 75 to 100,000 cases in China by January 25th, by this estimate. Well, that was 2 weeks ago, and I'm told that more recent projections, in fact, from some modelers are substantially greater than that. And Nick maybe can speak to that later on. So we're talking about large numbers of people. Many numbers are pretty grim. Frankly. So this estimate was about 75 to 100,000 cases in China by January 25th, by this estimate. This is just to say that we know that you can be asymptomatically infected and never have symptoms and recover, become uninfected, clearing the infection, that you can have a mild self-limited febrile respiratory infection, but clearly you can have a life-threatening pulmonary infection. And then there's a lot of question about what the case fatality proportion is, with estimates ranging from 1% to 3%, but everyone recognizing that that's undoubtedly challenging to estimate, because deaths may be missed, milder cases may be missed, so it's really very hard to know at this point what the case fatality is. Treatment, well, of course, supportive care for people in respiratory failure. I'm not a clinician anymore, but we have some in the audience who could answer fancy questions about supportive people with pulmonary failure and the like. There are clearly lots of headlines about medications that are being used to treat these patients, including antiviral drugs and even antiretroviral drugs. And you can see headlines like this, that these drugs are showing efficacy. But I would point out that this is based on individual patients being treated and getting better, and they might have gotten better anyway, right? So rumor has it the Chinese are doing a randomized trial of a couple of different regimens, but it's going to be a while until we know if any of these treatments really has a major impact on the course of this infection. So here are some things for epidemiologists. The incubation period appears to be in the range of 2 to 14 days. I think all of us in epidemiology are quite certain that this can be spread through droplets and perhaps aerosols. Aerosols are tiny particles that can remain suspended in the air. I could hit by Dean with with droplets from here, but droplets are large and fall to the ground by gravity. Aerosols stay suspended in the air. And for respiratory infections, we're often not sure whether both of these are plausible or not, and I would argue for this infection that remains to be worked out. It is not clear whether hand-to-hand contact can transmit this virus, but skin contact, or what doctors are learned to call fomites, or inanimate objects in the environment, such as toys, cell phones, pointers, things like that. But it's possible. We certainly don't know yet. There are certainly reports that the virus can be present in the nose and throat for 1 to 2 days before symptoms begin, which is true for influenza and a number of other viral respiratory pathogens, so that's quite plausible. A major question whether you can transmit this virus when you are not coughing and sneezing. And we can talk about that, but I would just say that the report from Germany suggesting that that happened there has now been questioned. And I think we really don't know whether asymptomatic people can transmit this virus. And the R sub 0, the R naught for this has been estimated to be between about 1.5 and 4. But clearly that basically means a major question whether you can transmit this virus when you are not coughing and sneezing. One infection, and we can talk about that, but just to provide some context, so I took this from the New York Times, but it's pretty useful, right? So along the y-axis is the case fatality, so how sick does this make you, what are your chances of dying, and along the x-axis are how transmissible it is by its R naught. So you can see the king of transmissibility here is measles at about 15. You can see that SARS was over here at about 2.5, although it varied with the time of the epidemic. And so you can see that this coronavirus, this novel coronavirus, is generally in that range, of somewhere in the range of 2, 3, something like that. Okay? And if you ask, what does that really mean? It means that this virus is readily transmissible from one person to another and quite capable of causing widespread infection and a very large epidemic. So what is the world doing in terms of prevention and control methods? Well, I put together my limited list so far. Okay, some people have said the Chinese should have closed down the live animal markets a long time ago. Presumably they're in the process of doing that now. You see people spraying, people walking around spraying street corners and hallways and the like with chemicals. I'm doubtful that that's an effective strategy, but it may reassure people. We do promote hand washing as an important public health tool for a variety of reasons, and that's certainly being promoted. Social distancing means basically canceling events and telling people not to go shopping, not to go into crowds, reducing contact with people. Clearly, there are now a lot of travel restrictions and border closings in place. Lots of people buying, wearing, and hoarding masks. And we can talk about the effectiveness of those masks in protecting you. So for those who care about the distinction, what's been done to Wuhan technically is not quarantine. It's what's called cordon sanitaire. If you don't understand French, that means sanitary cordon. So pretty easy. And what it basically means is you totally surround the area, you let no one in and no one out because they're infected people, and you hope to prevent further transmission. So it's really not individual level quarantine or isolation, it's isolating an entire community. Okay, and that's what the Chinese have tried to do with Wuhan, as I understand it. Isolation is what we do of someone who is sick. So if you're in the hospital with tuberculosis, we isolate you until you're not infectious. Quarantine is what we do to apparently healthy people who might be incubating the disease. So the terms are not interchangeable, even though everyone uses them interchangeably. You now know that we have, I believe, 3 plane loads of people have been brought back from China. 2 more are due this week. Those people, the federal government, for the first time in 50 years, is imposing a federal quarantine on those people. Quarantining 300 people is a non-trivial undertaking. So they're all being put on military bases where they can have a place to sleep and someone can feed them, and they can basically be kept from leaving. And so the federal government has the legal authority to keep them from leaving, and they'll be tested regularly to make sure none of them has coronavirus, and they're going to be there for 14 days, I'm quite certain. At the same time, we now have multiple cruise ships that appear to have had 1 or more cases, and they are now basically floating quarantine stations of the kind we used to have 100 years ago. And it's a lot easier to impose quarantine on 2,000 people on a cruise ship because you don't let them dock, you don't let them off, you don't let anyone on except people helicoptering in more food. So sort of easy to do in that sense. I just want to point out that the idea of keeping sick people out, oh, I'm sorry, I should have just said one other thing. We also sometimes have what's called protective sequestration. Nobody ever talks about that in public health. But instead of surrounding an area where there are sick people and not letting anyone in or out, This is surrounding a healthy community and not letting anyone in who might introduce the infection, okay? And so it's not done very often, but this is an example from the polio epidemic of 1916, basically saying that no child under the age of 16 could enter this town for fear that they might introduce the polio virus. This was also done in the flu pandemic of 1918, where small towns would prohibit entry by anyone from outside in an effort to keep the virus from getting in. So this is not new. How well who might introduce the infection. Okay? And so it's not done very often, but this is an example from lots of people are wearing masks, so you might have a hard time buying masks these days in many places. This is a really interesting use of modern technology here in China. So a drone will fly over you in China, and if it detects that you are not wearing a mask, it will yell at you. It will take your picture, and using facial recognition technology, the government can figure out that you, so-and-so, did not wear a mask, and you are potentially in big trouble. Now, I hope we're not going to start using that technology here, but that apparently is being done in China. Okay? You can see that we've got events at college campuses being canceled because of concerns about bringing crowds together. That's what that's about. We now do, as I've already said, we've got travel restrictions in place, which we can talk about. Basically, flights to and from China from virtually every country are now being prohibited by many countries. We do have a WHO declared global health emergency. Exactly what that means we could talk about. It basically doesn't necessarily mean there are more resources available, but it's meant to be an important declaration that the world has a serious problem, and it's meant to help raise resources. Vaccine development, well, this is the list I could put together of organizations that are busy making a vaccine. There are probably a dozen more that I don't know about or haven't read about. They're taking various different approaches, and some of them are talking about having a vaccine ready in 6 months. I personally find that a little hard to believe for a variety of reasons, but maybe someone with technology experience in the audience can convince me I'm wrong. But even once you start producing a vaccine, it'd be good to test it, make sure it's safe, immunogenic. So even if you could produce large quantities quickly, there clearly has to be some testing done before you would start giving it to large numbers of people. Diagnostic tests, initially the testing in the United States had to be done at CDC, so all the samples for those people under investigation had to be sent to Atlanta, imposing some additional delay in the results. As of yesterday, the California Department of Public Health has its kits. CDC has distributed kits to all 50 state health departments and other public health agencies. And the state of California, as I understand it, will be able to do the testing next week, now that they have the kits. In addition, of course, the academic centers and biotech companies are busy developing tests, point-of-care diagnostics and the like. So that's a rapidly evolving area. What are some of the social and societal impacts? Well, if you really want to know about social and societal impacts from a plague, I suggest you read Albert Camus' The Plague. I've been rereading it this week. It's a really depressing book, but quite a good description of how society can dissolve in the midst of an anxiety-producing, life-threatening plague. But clearly there are concerns about the effects of reduced travel and trade. I would point out that SARS was estimated to produce an economic impact of something like $70 billion globally, and it's likely this outbreak is going to cause a much bigger global impact than SARS did. So enormous economic impacts. We've got hoarding of masks. We've got problems with people from Asia or Asian Americans being stigmatized here and many other places, so stigma is a problem. We clearly, if you read letters to the editor, have reduced trust and authority if it wasn't low enough to begin with. And of course, in some countries, there are political ramifications. In China, certainly, this is a major political problem for the government of China. So just to say, there's an example of stocks. Of course, stocks go up and down. Oil prices apparently going down. Here's just a few headlines. Anti-Chinese sentiment. Our secretary of something said maybe this would be good for the U.S. economy because we'd bring back all the work from China to the United States. That was generally viewed as an unhelpful comment. You can see that now, as of yesterday, China is reportedly clamping down on news coverage, which is a very unfortunate circumstance. So lots and lots of things happening. The head of WHO, the Secretary General, yesterday put out a plan asking for $675 million to fund the global response. I'm not exactly sure whether Bill Gates will write that big of a check, but presumably some organizations will help provide WHO the resources it needs to ramp up its response. And then, of course, people say this is basically a pandemic. And I would simply point out that we do have a technical definition for the word pandemic, and you can decide for yourself whether you think this meets the definition of a pandemic. Some people would argue it doesn't. I would say that it's a distinction without a difference at this point, because functionally, we have multiple parts of the world under serious threat, and we are going to treat it like a pandemic even if it doesn't meet this definition. So I would simply point out that while I think our public health agencies at the local, state, and federal level are doing as good a job as anyone could possibly ask them to do, they are hamstrung, as we'll talk about in terms of detection and response to pandemics, by a shrinking budget, the elimination of a variety of federal programs under the current administration, and reduced resources, both globally for support of other countries in this type of response, as well as for activities by the CDC here domestically. So I think we're doing a great job, but some of you may know Laurie Garrett is a famous writer about the crumbling public health infrastructure, graduate of Berkeley, in immunology. So we can talk about that. So my summary, my last slide, this is clearly a newly emergent infectious disease. The situation is evolving very rapidly. It's pointing out, again, enormous gaps in the global capacity to prepare for, predict, detect, and respond to such infections. And the world has a lot of work to do. So, thank you. How are we doing at Berkeley?
Oh, wow. So first of all, I'm really privileged to be here, and I want to say right up front that I am not an expert in infectious diseases or in public health. I'm a general internal medicine physician. I happen to love a lot of things connected to those areas, as you heard, but I am absolutely deferring to the experts on all the scientific questions here. And we've been talking on and off over the last few weeks already, and I'll continue to do so. That said, my primary responsibility is to actually make sure that we're staying safe, but I have our time, even when things aren't happening, to make sure that we're making the connections and building the relationships that we need to have in place in infectious diseases or in public health right now, and that is mainly the public health department. So I have a very strong relationship with the government. We are under the jurisdiction of the city here, which is the basis of the we talk a lot, and ever since this whole thing. And then we also talk a lot with the campus leaders, especially within the fields of environmental health. Hold them to follow the rules of our local public health jurisdiction, which isn't that people realize, which is a good thing. We do also deal with isolation of a communicable disease multiple times a month, but I don't talk about it very much. So we have existing processes in place to handle it on the front line and to escalate as needed. Talk about it very much. So we have existing processes in place both to handle it on the front line and to escalate as needed. All of that said, emergency preparedness is a challenging field. This campus has been emergency preparedness is a challenging field. This campus has ever since this started emerging, so I guess I probably around, I think it might have been New Year's or so. That is not usually a huge concern right up front because we have a stockpile that we keep in place for those situations. More importantly, we start thinking about the staffing, and we start making sure that we are being thoughtful about our message, as calming as I can be while being realistic. That's actually huge, is handling that piece of things. I love that we get to talk about the science and the medicine more in here, so I'm looking forward to that part. Then, as it started becoming clear, talking about things like making sure we have isolation spaces on campus, which we do. We have, I will say, we have done some testing. I'm not going to talk about how many and all the rest, but that's sort of confidential information. We have not had any cases here, thank goodness. So I've been really happy with that. And honestly, if we hadn't been doing testing and hadn't been doing screening, I would have been surprised. And if people say they're not doing that, then they're not paying attention. So this is part of our routine work. Right now, I'm sort of waiting. There's like this little calm, a little lull happening, and I'm waiting for something local to happen. I'm just going to say we've been lucky thus far, but we will be most definitely escalating as we do. And we are activated at the EOC, so the Emergency Operations Center on campus, as well as through the system, as well as at UHS. So I'll stop now, and then I'm sure other questions will come up.
Thank you. We're a public university. We can only afford one microphone.
So thanks for both of those presentations. I think that was incredibly informative, and I'm excited to dive into this topic. I wanted to just get right to it. I mean, you kind of talked about some of the challenges in these outbreaks, and there are a lot of challenges, but I wanted to start with kind of the early stages and that sort of identifying these outbreaks when they occur. What are the challenges there? Why are they hard? Can we even predict them? And why is it so hard to do the surveillance to even identify them right away? I mean, this was actually pretty quick, is my understanding. Presumably the first cases in China were at the beginning of December, and then they were really publicized by the end of December, and then now we're 2 months into it, I suppose. But that still is a month before there was really any publicity about this brand new coronavirus. Can you talk about why that's a challenge? Why is that so hard to do?
So first, I think if you read the newspapers, you'll know there's a fair bit of back and forth about how transparent China was with regard to this, and certainly reports that there may have been delays in China. Now some discussion about whether those were primarily at the local level, of people being unhappy or unwilling to share information with the national authorities. So I personally can't tell what went on there. I think there, certainly in SARS there was a great lack of transparency, which contributed to delays and to a bigger problem. I think leaving that question aside, I think the more interesting epidemiologic question is how do we do a better job of so I guess there are two issues. One is predicting, for example, which viruses in animals might be more likely to come out and get us, if you will. And I'll be happy to talk at length about why I think that's particularly problematic. But beyond that, the question of can we detect clusters of illness, unusual clusters more rapidly than we do. And of course, the old-fashioned surveillance method of either laboratories or doctors reporting things that we have in the United States is notoriously imperfect. Certainly is problematic for detecting a completely new infectious disease. There's lots of interest in what's called syndromic surveillance, which I'd be happy to talk about, or using artificial intelligence or a variety of big data approaches to finding clusters, here or there that you can then respond to more quickly, as opposed to waiting for doctors to. So I think there are certainly people in the room who know more about risk communication than I do. It's a really important part of public health. Trying to balance the information so that you're giving people a good message that there's things you're doing. I don't, that's not easy. So one of the things I do every night is I read the letters to the editor of the New York Times, people responding to these different articles. And, just as in another field I work in, vaccination, you see an astonishing range of points of view. So, people who say, what are you worried about? It's only killed a few hundred people so far. That's nothing compared to smoking or whatever it is, right? And other people who say, shut the door, don't let any of those people in. This is a worldwide catastrophe, and everything in between, right? So in the general public, we have all manner of different points of view about this, and the challenge for public health is to do the best job of balancing, not creating undue panic, but trying to protect the public's health. And I would argue that the whole point of all this exercise, if you're a wealthy country like the United States, is in fact to prevent a situation that exists in Wuhan at the moment. We do not want widespread transmission of this virus in the United States. Even if it, quote, only kills 1 to 2% of the people who get sick with it, we prefer not to have that. So if we can, through some of these activities, prevent that from happening, maybe in a year we'll have a vaccine, and then we'll have the interesting question of, should we use the vaccine? To whom should we give the vaccine? Et cetera, right? But that would be a luxury that we would have, a year from now or 18 months from now. So part of it is trying to see if we can keep things out, because you can see the kind of panic and economic harm that this kind of illness can produce. But you're right, getting the balance right between undue panic and anxiety. It's clear that some people don't like being reminded to get a flu shot in the middle of all this, right? We all in public health say, by the way, if you want to protect yourself against respiratory infections, we have a not so good, but better than nothing flu vaccine, and you should get it because it's flu season and flu kills more people than blah, 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 right? There are a lot of people who are not happy with that message, even though it's a fully accurate message, right? So I don't know if we want to start, we have a hand up, I don't know if you want to.
Yeah, there are a few hands up, so I don't, if we're ready to handle it, I'm fine.
It's totally fine with me, we don't have to keep blabbing with each other. We can.
From a medical perspective, why is the virus so deadly? What happens?
So we can repeat the question, but nobody has the answer.
Why is the virus so deadly from a medical perspective? Do you want to take first pass? You want me to? Either way, I mean, I'll tell you. Yeah, I mean, I can tell you as a pure clinician what I know, and then anyone who wants to add much more interesting detail can. My understanding is that there are a certain percentage of people who end up with essentially an inflammatory response in their lungs, and they end up with a pneumonia. But it's not a typical bacterial pneumonia, and I don't think we know why some people or who necessarily is getting sick with this, although there has been some speculation, and this is where I pass it off. I also think we'll know a lot more really soon, because a lot of people are studying it. You want to speculate some more?
Yeah. So I would guess that pretty much the entire human race is susceptible to infection with this virus. I don't know any reason why people would be immune to it unless they've been exposed to a very similar virus and there's cross protection. So I would assume that most of us are susceptible to infection with this virus, and as is true for pretty much most respiratory viruses, some people will be asymptomatically infected, some will develop a mild self-limited illness, some will get really sick, and some will die. And that's just a continuum. It's pretty clear at the moment that, at least in China, the overwhelming proportion of the deaths are in older adults. I'll use the term older adults, old people like me, but particularly those who have underlying medical conditions, which is exactly what we see with influenza, right? So in that sense, it may be no different than influenza in terms of who's likely to get really sick and be hospitalized and die. One of the interesting things that's an unknown is how many children are getting sick. And at the moment, the data would suggest that, as with true with SARS, very few children are getting diagnosed. And most people are saying that that's because they probably aren't getting very sick and no one is testing it. And I'm sure that that's part of it. But at least with SARS, and probably with this, if you think about how it started, it almost certainly started in an adult, exposed into a bat or to a pound civet or whatever it was. And we tend to think more of children infecting adults than adults infecting children. And so how much children have hung around wet markets, how much they've been exposed to sick adults who are bedridden, maybe a cultural phenomenon, but I'm not sure whether children are being equally exposed. But if they are, then they clearly are not getting as sick as adults, right? But that's very common for respiratory pathogens. Eva. Eva has a virology answer.
No, this is not the virology. It's just that I've just heard that it is moving down into like the 30s. So having talked to Aubrey 1 minute ago. No, just that it's now moving down in the age range, so there's more severe cases in the 30s range is the latest news. So.
Okay? A distinguished vaccinologist in the audience?
Actually, a different question for you, for the distinguished epidemiologist. The question I had is those people on the boat, which you listed as being quarantined. And I want to understand the logic there, because they started out with one case, now I think there's 5 or 6. And do those people stay on the boat till they're either all seropositive or all dead? Or how do you do that? Because each time there's a new case, you have to sort of start the window over that again in terms of keeping people there. So what would you recommend if you were in charge of that boat?
So let me begin by saying what my wife always tells me, okay? Which is that it's people in public health who do public health, professors just talk about it. Okay? It's people in public health agencies who have the responsibility for making those tough decisions, and not professors. Nobody cares what professors think. Okay? So, I mean, the point you're raising is obviously good, but it's also true in what apparently is being done in Wuhan, in terms of forcibly putting together large numbers of people, some of whom may be incubating this virus and some of whom may not, some of whom may have influenza, and you put them all together in a tight space, and guess what? You might be promoting transmission within that area and dooming some people to infection who might otherwise not have gotten infected, and there's certainly a concern about that. So, you know, I guess, first of all, and I'm sure this is all true, I'm sure people are being checked regularly for symptoms. I would hope that people who are symptomatic are wearing masks and getting as quick a testing as possible. And, you know, that people are doing their best to try and not infect other people while they wait out their incubation period in utter boredom. You know, shuffleboard only gets you so far. You know, there are no drugs we can give people. There's obviously a concern about having people get off the boat and go to Tokyo or, you know, wherever it is, and try to follow them there. But this is clearly one of the problems with quarantine, right? Quarantining large numbers of individuals is just really hard. And you know, you either post a guard outside their door and you provide all of their needs in their apartment because you don't let them leave, right? Or you put them all on a military base and try and ensure that as little transmission is occurring as possible. I don't really have a good answer, and I don't know exactly what they're doing.
I just wanted
Professor Jewell.
I just wanted to correct the information. So there's 2 boats under quarantine right now. The Diamond Princess in Yokohama has about 40,000 people on board, 3,700 to be exact. There are currently 20 confirmed infections on that ship. They've all been removed to isolation in hospitals in Japan. About 10% of them have been of the other passengers have been tested because they're showing symptoms, and as other people have pointed out, it's the cold and flu season, so that's not a shock. I think that a third of those people have tested positive as of 10 hours ago, so that takes it up from 20, potentially higher. The media, officially there's only 20 people. So they're literally having to wait out because that infection clearly spread within that ship before it was quarantined. And now they have to wait for the incubation period before they can allow people. But they haven't tested everyone. There's a lot of people on that ship who are showing no symptoms and are just stuck so far.
I wanted to ask, how is this response different or similar to the response to SARS?
You mean globally, or in China, or here, or globally?
At least in the U.S.
So I think people were sobered by the SARS experience. You know, the hope was that China's response was more transparent and less obstructed than the SARS experience. As I said, I think that remains to be fully elucidated, what happened in China, if it's ever known for sure. I would say that this response is, at least internationally so far, more robust because of the experience with SARS and because of an increased concern about problems like this. But I'm not sure that there's any data to support that statement, and so I'm not totally sure that that's true. You know, the world community can sometimes move fairly slowly. You know, the World Health Organization is another great example of an organization that in theory should be able to do an astonishing amount in a situation like this, but in practice doesn't have that many staff, doesn't have that much money, and really is limited in its capabilities. So they have to ask someone to give them money. And how long will it take for someone to write the checks? I don't know. But in the meantime, their capacity is really quite limited. And so they often, for example, rely on partners like the CDC in Atlanta, because if they need to, CDC can send 500 medical epidemiologists, and in fact they're doing that. Not to China so far, but no thanks. So the World Health Organization is constrained by its limited resources and having to wait for people. They don't have hundreds of people sitting there in Geneva waiting to get on a plane. You know, but I think people are not worried enough about this that the response, I would say, has been perhaps a little better than the response to SARS, but others may have a different view.
All the way in after. I'll just add that from a local perspective, I found in a box a few weeks ago the 2003 SARS Emergency Preparedness Plan. And so I will say that at least locally, that experience did help things move faster here. So we do live and learn a little bit.
Just a real quick, from my perspective in the media, I wasn't covering it at the time, but I did actually spend the last few days looking through our own archives of how the Chronicle covered that. And one thing that was remarkable to me is it felt like just reading the articles that there was a lot more chaos with SARS, a lot more sort of, there was one incident where a plane landed in San Jose and 5 passengers, the pilot reported that he thought there were cases of SARS on the plane, and so they had it on the tarmac, you know, ambulances surrounding it. They took these passengers off the plane, brought them to the hospital. It turned out they had colds. I mean, the people had been sick in Tokyo with colds, but there was this sort of like, not panic, but really chaotic response. And there were several examples of those kinds of incidents where it was clear that it was just, there's a big range of the way public health agencies responded to it from county to county that doesn't seem to be the case to me this time around. It feels a lot more focused, a lot more consistent, and consistent messaging and things like that. So I thought that was kind of, just in a glance over the articles, it felt to me like it was a very different response.
One more thing to add, just anecdotally, I think the effect of SARS is still felt many places in the world, in China in particular, and so we did have a number of students who came forward quite early who were much more panicked than they might have been because their parents had handled SARS, and so therefore presented earlier, which is actually a good thing from a public health perspective, that we could engage with them sooner. So I think it has helped, again, get things moving faster and more carefully.
If this outbreak were to occur in the U.S., what steps would you recommend our government take, balancing on transparency, public safety, and anxiety? Second question, is our health system ready to face this challenge?
So I'm hoping we won't use drones to identify people who are not wearing masks and, you know, and identify them individually. So I'm hoping we won't get to that stage here. You know, I think what we would be doing under guidance from CDC and, you know, and local partners and clinical organizations would be pretty much what is already being done, but on a much larger scale, right? So we would be testing much larger numbers of people for this virus. We would be isolating people if we suspected that they were infected. We might be quarantining people. There are a lot of questions about whether we would be canceling sporting events and large gatherings and graduations and, you know, things like that. I think, you know, there might be circumstances where people would get that concerned that they would do that. But I'm not sure there'd be an enormous difference from what we're doing now, but it would just be a much, much larger scale. If you're asked the question, do we have the clinical capacity to deal with the problem that China's experiencing in Wuhan at the moment? If that's your question, the answer is no, right? We have spent the last 20 years reducing the number of hospitals, the number of hospital beds, the capacity, because it costs money to have excess hospital capacity, right? So if all of a sudden large metropolitan areas like New York or San Francisco had thousands of people coming in and needing respiratory support in an intensive care unit, I don't know if we have any doctors, real doctors in the room, not like me, but it would be a problem. We don't have enough respirators. We don't have enough, you know, we're not clear we'd even have enough nurses, right? So no, we don't have enormous excess capacity. We've spent a lot of effort to reduce excess capacity to try and save money on healthcare costs. The reality is that if you need to, China built 2 hospitals in 14 days? I don't think we could do that here. Whatever the quality of the hospitals is, I think it's hard to envision doing that, right? You know, the military has a limited capacity to quickly set up, you know, care for reasonable numbers of people. We're talking about a few hundred people maybe, but 20,000 people needing respiratory support in New York, I don't think so.
I do still see patients. I'm still a real doctor. There was.
Oh, sorry.
Okay, can you hear me?
Switch the mic.
Switch the mics back to the other mic. Where's the other mic? Okay.
Sorry.
I want to add one other thing, which is actually one of the things that's most on my mind right now, which is the supply of a lot of our things that we use in these situations, including various kinds of masks. A lot of that comes from China, at least somewhere. And so we are experiencing major problems in this state and likely elsewhere in the United States in terms of not having any access to those supplies really quickly. And that, you know, I mean, it's obvious, right, that would have happened. It's happening. And so one of the biggest things I do is spend time on these state emergency calls saying, we have 1 week of this left. We have 2 weeks of this left. We need help. What are you doing about it? How are we escalating the larger public health response to get those supplies? So, you know, that's one of those little nuances of how dependent we are, all of us.
So if I might just say, with regard to supplies, many of you know there's a national stockpile of various things. Some may not be totally relevant, like we have a dose of smallpox vaccine for everyone in the United States, just in case. Tax dollars hard at work. You know, but that national emergency supply includes various antibiotics. I wouldn't be surprised if it includes you know, things like masks. And if and when it needs to be deployed, obviously the federal government will decide to use that emergency supply of various things. So we do have some preparedness. You know, for emergencies of a substantial scale, but I honestly don't know how long they would last.
My voice is loud, so I'll just yell. I understand that the FDA fast-tracked the diagnostic kit approval that you've just been distributed to the state level. Can you speak to the sensitivity and specificity of that test?
No. I don't think anyone has public data about the sensitivity and specificity of these new tests. So they're not published. So I'm sorry, but I don't think so.
Just beginning, let me say, I'm from Wuhan, China. I was born there, grew up there, and I went to colleges there. So actually, a couple things I want to just see if it's maybe not official, but the disease, the first case was officially identified December, beginning December, but actually in November in Wuhan, there's already, they say there's a rumor about this strange lung disease, and the SARS-like the lung disease. So then there's a lot of just, oh, that's a rumor. But I think this is one thing. I think the lessons we learned from the Wuhan spread, I think number one, I really agree with what the art said, is the local public health. Aging is very, very important. But what at the beginning of December, what Wuhan public health actually announced is, say there is no person-to-person, transaction. And when so after I thought that at the very early stage, I thought that was a mistake because you didn't know yet, so you shouldn't, announce. I think that's one thing. Second, I would say the lessons we learned, but I don't know if we can correct, is bad timing, because there's a Chinese New Year. It's really bad timing, and there's a big transportation seasons, and the Wuhan closed down was just a little bit too late. I think if Wuhan closed down a little earlier, I think at least we can prevent this global spread. But how could we know? That's what the government said. One other thing I think I would like to say is the death row, now what the public know, or WHO know, I think it is underestimated. The reason is, okay, it's really unfortunate. Reason is for my own. I have family members still in Wuhan. I have friends, a lot of friends there. But what they even say, unless you have a family member get infected, you really don't know the truth. So I have a friend was telling me one of her friends died from this, from have the symptoms until die, never get finally diagnosed, never even get into the hospital. So which means I'm not blaming any Chinese government or local government. It's maybe even the local government even didn't know, because they just, so this is, I would say, is more urgent situation. The death rate is much higher, so that's what I want to just make sure. But I think where here is I actually think is what we can do and what we can learn from these lessons. So I would say, I have just a couple questions for Art or for any physicians here, because now China changed for the diagnosis using PCR kits. It's great, but at the beginning, the reason is 2 weeks ago, they didn't have enough medical supplies, so they didn't have that. So that's why they just have to watch the people die. But now they do have, but still not quickly enough. Oh, now they're trying to get everybody in Wuhan who can run the PCR, trying to do it, but still very limited. So now they change it to using the chest, either chest X-ray or chest the CT. So I'm not a physician. I want to see if that's really good diagnosis. This is the one thing. Another question is, how about treatment? Now the treatment is using the plasma from recovered patients to give to the, I just want to ask you this 2 questions. By the way, I'm not coming to see if you wear a tie, but I just want to see if Art wear the mask. If Art didn't wear a mask, I think you wear.
I didn't even wear a mask. I didn't even wear a mask in Hong Kong during SARS. That's how stupid I am. Clearly, if the case definition they're using is different, that makes it even more confusing in terms of what the true numbers are. Chest X-ray or other non-specific tests like that is clearly not going to be as definitive for coronavirus as a coronavirus test. So I think that's just going to confuse matters more. But I think it's very clear that a lot of sick people have not been tested. And so it makes it very hard to know what's going on. In terms of using plasma, clearly there's an interest in potentially seeing whether plasma from recovered individuals might have an antibody or some other material in it that could be useful therapeutically, and potentially then lead to monoclonal antibodies or something like that. So I'm sure people are trying that, but I have no idea what the results are. We also have some people over here. But
as we know, it's very difficult to predict or prevent such an outbreak. So maybe after the epidemic, it always have the problem with lack of doctors or beds in the hospitals or other medical resources. So in that situation, how could we deal with those mild patients? Because if they are mild with little or no syndrome, they maybe just chosen home isolation. But this time in Wuhan, there were many cases reported that one person is sick and the whole family infected. So how could we do for these mild patients? Maybe there are the big reason for the epidemic to the transmitted virus and how Hong Kong did in 2003.
I really don't have the answer to your question. Again, clearly if there are lots of people who are mildly ill and not getting diagnosed, it just makes the whole epidemiologic picture even more complicated and difficult to interpret, right? So I don't have a good answer to that, but I think that's obvious. You know, I think, again, we've said that compared to the SARS response, this one is robust, but I think that people in Wuhan are totally overwhelmed, frankly. And you know, I'm sure they're doing their best, but I'm pretty sure they don't have the capacity to do what someone sitting in a chair in Berkeley would suggest that they do, right? So.
Here locally, we look for isolation not with your family, but on your own. And of course, if we get really overwhelmed, that's going to be very challenging, which is why we're anticipating how we can use larger spaces and maintain enough distance. And that is a place where we might use masks for people who are sick. And all the rest of it, but it would be very, very challenging.
My name is Minal, but anybody that was previously infected with SARS, have you seen any protection from this novel? And they might start there for developing a vaccine?
So the quick answer to that is I have no idea. It's a perfectly plausible hypothesis that somebody who's been infected with the SARS coronavirus might have partial or full immunity to this virus. They're relatively closely related. I'm pretty sure no one has a clue what the answer to that question is. But it's plausible. We need more microphones. You're a state university. You need to get more microphones.
How do you foresee this will ultimately dissipate, to the point where threat, especially regarding mortality, goes away, maybe to the point that we don't really think so much about SARS or bird flu, for example?
You're getting your exercise. So first of all, I think the parallel with bird flu is, I wouldn't try and make that parallel. Bird flu, H5N1, or highly pathogenic avian influenza viruses are really very different for two reasons. One, they have an incredibly high case fatality proportion in the range of 50%. So they're really bad when you get them. But B, you basically need to kiss a chicken in order to get them. I mean, there's basically almost no human-to-human transmission of that virus. And by the way, I do think that and there is an outbreak apparently of bird flu at the moment in China as well, which I presume is H5N1, but I suppose it could be a different virus. But actually, I did want to say something about bird flu, which is that when I was on the WHO advisory committee about immunizations back before the flu pandemic of 2009, people were really worried about bird flu in Vietnam and other Southeast Asian countries, where there were several hundred cases and 100 deaths or more. And so, based on the concern that that virus might, it had 2 of the 3 characteristics needed to cause a pandemic, right? One is it really makes people sick. 2 is nobody in the human population is immune, but it didn't have the third. The third was transmissibility from person to person, right? But people were so worried about that and predicting that, we made millions of doses of a bird flu vaccine that, as far as I know, were never deployed. And in fact, I emailed my friends in Geneva this morning and said, by the way, is that still in storage or did you flush it down the toilet? Because it was right past its shelf life years ago. And it cost tens of millions of dollars to make, and it's never been used. Right? So predicting which viruses are going to cause a pandemic and make vaccines and be prepared and all of that, I'm just saying, I think it's a hard thing to do. Okay? So I wouldn't, I'd say with your parallel bird flu, but your other question was, oh, will it dissipate? Well, that's certainly, we hope, you know, that control measures, et cetera, that whether it becomes an endemic infection, whether we have periodic outbreaks, whether it goes away like SARS, I think it's too soon to tell, but it's a little hard for me to see this disappearing completely the way SARS did, given where we're at the moment.
Thank you, Dr. Reingold and fellow panelists. How and what policies should be enforced on airline carriers and the larger travel industry if they do not comply with WHO protective measures with respect to waiving cancellation penalties and providing full refunds to their passengers?
Is there a lawyer in the room? No idea. You need about 12 lawyers to answer that question. Seriously, we need some people who know serious business law and international law to speak to the question of, is there any enforcement mechanism? Can you force airlines to give people refunds, et cetera, et cetera? I have no idea. Whether there's legal recourse, I don't know. Any lawyers in the room?
In Toronto, during the SARS outbreak, there were people who were called super spreaders, which means that R0 is not finite and fixed, but changeable. What did we learn from super spreaders and that concept? And was it a problem of the patient, or had their immune systems done something to change the virus?
With Nick Jewell in the room, I'm going to attempt to make an answer, but Nick undoubtedly can correct me. So first of all, R0 is, fundamentally what we in public health do is try to reduce R0 to less than 1, right? So whether it's wearing masks, whether it's vaccinating people, whether it's giving prophylactic medication, whether it's social distancing, we want to get the R0 below 1 so the epidemic will go away, right? Everything we're doing is focused on that. And it's almost certainly the case that the R0 was different at different stages of the SARS outbreak. Right? The super spreaders, as I recall, certainly some of them, were fundamentally, what we know about SARS was that you are most infectious when you're most sick. Okay? So people who were in a bed, in a hospital, with a lot of virus in their stool, with a lot of virus in their secretions, those were the people most likely to transmit to other people, which was why healthcare workers were at such enormously increased risk. So stage of the illness matters in terms of how infectious you are to other people. But in terms of super spreaders, Nick, do you have some wisdom to impart?
Not about this new coronavirus, no. I don't think we know.
Yeah, I mean, I haven't heard about, I think there have been 1 or 2 anecdotal reports in the press about maybe people who were, infected a lot of people, but at the moment I don't know the answer to your question. So. Come on, Eve.
Okay.
My wife's plane doesn't land until 9:40.
Hi, I'm an infectious disease physician. I take care of people with infectious diseases in our local community hospitals here in Berkeley and Oakland. And in recent years, an increasing and alarmingly high percentage of my patients are living on the streets or in tent encampments. And I worry a great deal about what will happen if this virus starts spreading among our unhoused neighbors who are already suffering in great numbers from vaccine-preventable illnesses which spread rapidly among tent encampments. A patient recently said to me in the hospital where he was because of 2, not 1, but 2 vaccine-preventable pneumonias, everyone in the tents is sick. So I worry both in terms of morbidity and mortality suffering for these people, and also about increased stigma for a population that already suffers a great deal because of backlash. So I wonder how, as a public health community, we can marshal this excitement about public health and infectious disease to draw attention to a current public health crisis in our community, and also get out ahead of a potential magnification of that crisis should coronavirus start spreading among tent encampments.
Is the governor here? You know, I agree with everything you said. We clearly have outbreaks of vaccine-preventable diseases in homeless populations, like hepatitis A, for example. We clearly have dreadful sanitary conditions and people living in unacceptable circumstances. And I think everyone knows that the legislature recently failed to pass at least one piece of legislation that some people thought would help with the homeless problem. I'm sure there are different points of view about that piece of legislation, but we have a serious problem, and if this can help focus people's attention on helping the homeless, that would be great, but I'm not totally sure that's what's going to happen.
One last word? I'll just add, Amy, that unfortunately what I could see happening is isolating those populations, not really tackling the underlying problem. And I just want to put in another plug. The public health nurses will go encampment to encampment and street to street to find people, and they do that. Again, there's not enough of them. So yes, we're on the same page.
You know, I will say, well, more immediately, I actually just talked with San Francisco about this specific problem. I haven't written the story yet, but just in this current outbreak, they are actually having those conversations about what they're going to do if they find cases in like SROs, in encampments, and they're actually coming up with, you know, where people will be isolated if they identify cases. Because if somebody's in an SRO and they test positive, they can't stay in that SRO. That would be a disaster, and same with an encampment. So to me, and they didn't really have an answer for this, the harder thing would be like, right now, I think every case in the United States has been identified because that person self-reported essentially. Like they were caught, you know, given pamphlets, given information at the airport, and then got in touch with their public health department, and you know, were kind of followed the whole way through. That's not going to happen, I would imagine, in you know, these other populations, but probably if those populations are affected, we're at a different stage in this outbreak anyway. But that being said, the bigger issue you talk to, I mean, as a journalist who writes about those things all the time, I can tell you it feels like a never-ending battle to us too. You know, write about these things, and you try to drive these things home, and I think people get a little weary. It feels insurmountable, especially with the homeless situation. It just, you know, I write about HIV and AIDS a lot, and you know, it just feels like until we tackle this homeless problem, that there's kind of limits to what we're going to be able to accomplish in getting real improvements in health disparities, and addressing a lot of these conditions. And there's amazing efforts happening in communities to reach these populations and to kind of deal with people where they're at. And it's incredible the work. Every time I talk with folks who are on the front lines, I'm just so amazed by the work that they're doing and their persistence and drive. It's incredible. But obviously, at a certain point, there's just so much you can do. And I don't know what the answer is. You keep writing about it, but there we are.
So I was told that we got cut off this conversation because people out in the atrium are already starting with the food. So I hope you found this conversation just as informative and as fascinating as I have, and also just the kind of realizing the critical importance of investment in public health infrastructure. So please join me in thanking our speakers. Now, if you're interested in getting announcements for future events like this, make sure that you leave your name and email with us before you leave. So this officially concludes our program, and please join us outside in the atrium for whatever food is left.